Thank you, Dr. Palmer. Thank you to the foundation here for having us. Hello, Arizona. All right. If you're able to and you desire to and you want to, stand up for a second if you can. Let's take a nice stretch real quick. We're running long, detailed talks here. Just stretch it out a little bit. Huh? All right. There you go. Okay, now you can sit down. Okay, good. That's the icebreaker. Very good, everyone. So as you heard from our talks this morning, I want to just run through the standard of care in myelofibrosis in 2025, and then John Mascarenas will take us through the investigational clinical trials. But how appropriate that I stole this slide many years ago from our own Ruben Mesa to show you back here. And I still love this slide. It says MPDs because, as you'll remember, prior to the JAK2 mutation, we thought of the MPNs as Ds, disorders. And so that shows you, as Dr. Nangalia showed you with CALR, this is the 20th anniversary of the JAK2 V617F being elucidated. Not 200 years, not, just 20 years ago. So it's a relatively new science. PV, we heard from Rajith. ET, we heard from Rupali. I'm going to tell you about myelofibrosis. If we can agree, the earlier stages for you in the MPNs are dominated by talk of vascular events, blood clots, bleeding, and the worry, perhaps, the fear, the quiet background fear that you may one day transform to myelofibrosis. For those of you already in the MF state, you know that you can get there in two ways. Either you walked off the street, de novo myelofibrosis, or it arose out of these prior ones. The problem and the reason why we must meet to talk about it is this is a deadly disease. Those of you facing myelofibrosis, we think maybe only a median overall survival of about 7 years, but obviously people can live for decades with the lower risk, but maybe even less with the higher risk. If you're living with myelofibrosis or facing it, this is a cancer. This is a deadly disease. It can cause wasting. It can cause cytopenia, so low blood counts, anemia, thrombocytopenia, blood transfusions. You may even look sick to friends and colleagues, and of course, unfortunately, an early death and transformation to AML. And so that's why we want to talk about myelofibrosis here. As you're hearing, this 20th anniversary, we meet here for JAK2. It's amazing that several independent groups were able to report on this quickly. And although it doesn't make up all of our patients with MF, it's about 50 to 60%. I did my early work at Johns Hopkins at that time. 2004, people were milling around, and then 2005, everything just changed when this JAK2 V617F was elucidated. At that time, I was working with Dr. Moliterno and Dr. Spivak, and as our earlier speakers showed, this variant allele fraction or allele burden may matter among these three cousin diseases that we've been talking about all morning. But here, to get to the treatments of myelofibrosis, how wonderful is it that we have Dr. Nangalia, who came here from the UK to present to us on her own discovery of CALR, which already now, as you heard, is 10 years plus in its discovery. So JAK2, the most common. Yeah, let's give her a round of applause. That's right. And if we may say, the way Jyoti presents, she's able to distill what was a complex scientific journey in a way that we can all understand. So that's a really nice credit. But what she showed us here with JAK2 first and now the CALR is that we have something to talk about for diagnosis, prognosis, and maybe even treatment. So I think that's something important, and this is an even more compressed timeline than the JAK2. Besides that, there's a third mutation you heard about called MPL, a little bit less frequent than the other two, all of these essentially signaling through the same JAK-STAT pathway, and now as we enter the mutant-specific pathway, we have very specific ways of targeting each of these. I mentioned prognosis. These are called Kaplan-Meier curves. You'll see them a lot. What they're trying to tell you is what's the expectation over time. So, the x-axis will be time, in this case in years, and the y-axis, as you can see, is the variable. Sorry about that. What I'm trying to show you here is by mutation. So if you have the CALR alone in myelofibrosis, this is thought to be a better thing to have by itself. Maybe survival is measured in decades for you. JAK2 and MPL, you can see there, maybe a little bit less. And then the really scary one for a lot of us is the triple negative, which probably means you have something else, ASXL1 mutation, DNMT3A, EZH2. So let's talk about all of these. There has to be some diagnostic criteria. You saw it from the previous speakers. I think really basically myelofibrosis has to be a diagnosis not only in the bone marrow lab, but you and me in the clinic. So clinical pathologic diagnosis. So the pathologist has to see scar tissue, myelo from the bone marrow, fibrosis scar tissue, and and you have to have either one of the mutations, or if you're triple negative, if you sequence deep enough, almost all of you will have one of these. Again, ASXL1. I think it's important to say for all three of these MPNs, we need to be ruling out CML, chronic myeloid leukemia, which is the cousin disease here, and that can be ruled out quickly by checking the Philadelphia chromosome or BCR-ABL. There's a host of minor criteria, but as I mentioned again, it's not just a diagnosis you can get from the lab. You do need to have some clinical correlation to actually be called myelofibrosis. So you make the diagnosis, you've got the molecular mutations. Now in the clinic, a lot of you know about this, we're trying to stage you. It's not like breast cancer where there's a stage 1, 2, 3, 4. The blood, after all, is everywhere. So we need to use a low, high, intermediate, high risk kind of a strategy. The first one, I'm actually amazed to tell you, this was 2009, our colleague Dr. Cervantes in Spain. That's the IPSS, International Prognostic Scoring System. The aim there was to take common things, 5 variables: age, white blood cell count, if you have constitutional symptoms, peripheral blasts, and anemia, something you can quickly do at the bedside in the clinic to tell someone if you're low, intermediate, or high risk. That matters. If you're low risk, perhaps we can watch you with observation alone, transfusions, growth factors, maybe if there's a clinical trial for early intervention. But if you're intermediate to high risk, which is the subject of this talk, that's when we're starting to think about therapeutic interventions. The JAK inhibitors, as you're hearing in the earlier disease, clinical trials, even stem cell transplant, which is really the only curative modality for myelofibrosis. The other key that you'll hear from John in the next talk will be, can we combine and go beyond the monotherapy? But for here, I'll focus on the standard of care. Well, the tough thing in our field is that there's so many scoring systems, even we can't keep up. So from the IPS or IPSS, then there was the DIPS, the dynamic scoring system, which really is clever. It actually aims to just weight the anemia, the low hemoglobin that many of you suffer from is actually one of the more dominant issues in our field. Then there's the DIPS plus, that's right. So then the Mayo team added cytogenetics, platelet count, and transfusion. And then that's right, we have even the MIPS and the GIPS and everything, molecular, genotypic. You're getting the strategy. What I think is great about each scoring system is that they're available online. You saw from Dr. Nangalia the personalized kind of scoring system, and it's trying to incorporate these molecular data, not just in the academic world. So for myelofibrosis in 2025, as you know, there are the only one class of drugs, the JAK inhibitors. Interestingly, they hit the entire pathway, so not just if you're JAK2 mutated. So question one, hey, how come I'm on Rux when I have a CALR mutation? Answer is it hits the entire JAK-STAT pathway, the wild type pathway, as Dr. Nangalia said, and not necessarily the mutation specific. That era is just starting. So 4 approved JAK inhibitors. This is the outline, so this may be a nice slide to take a picture of or just to make sure you have this in your mind. Ruxolitinib or Jakafi, the first in class approved. This was the COMFORT 1 and 2 studies over a decade and a half ago. Longest running first in class JAK inhibitor. Then Fedratinib in August of 2019, which, can you believe it, was only 6 months before the COVID pandemic. So August 2019, the second JAK inhibitor approved based on the Jakarta studies. Pacritinib, the third JAK inhibitor, only approved, can you believe it, in just February of 2022 for platelets less than 50, led by Dr. John Mascarenhas. And then momelotinib was just a few seconds ago, September of 2023, approved for myelofibrosis with anemia. Each drug approval represents strategic planning on our part as investigators, yours as patients and advocates, and credit the pharma stakeholders who are helping to look which niche can we get the drug approved in. What do I mean by that? The first 2 JAK inhibitors, Rux and Fedratinib, are pretty similar. Big spleen, symptoms, platelets above 50, that's okay. But the pacritinib aims to go if you have platelets less than 50. That's a clever and smart approval strategy. And then the momelotinib for anemia. So you can see each approval trying to go after things that people are worried about. Let's do a deep dive of these 4 approved agents for our talk. The first one, ruxolitinib, as we mentioned, I can't believe it's been since 2012. So really coming up into a long time, a decade and a half since these approvals. And I remember some of the first patients that we treated. This is with Serge Verstovsek with us at MD Anderson and Professor Claire Harris in the UK. Some of the patients, many of you may know or are still these stories where people were in wheelchairs, so sick, so advanced, and were able to really get up and improve the ECOG performance status. That's because it's one of the few drugs that makes you feel better for most people when you start it. It was Rubin's scoring system, the total symptom score, that gave us that language that the symptoms of myelofibrosis, itching, fatigue, bone pain that many of you suffer from can not necessarily immediately, but very quickly be relieved by this twice-a-day oral drug. So that's ruxolitinib, first-in-class JAK1, JAK2 inhibitor. But what I want you to remember from the academic side is that it was approved based on these data. This is the COMFORT-1 study, New England Journal. So compared to placebo, which is so we had no treatments back then, 42% of patients with the ruxolitinib versus essentially nobody with the placebo got the primary endpoint. That's what I want you to remember from this. The primary endpoint for myelofibrosis trials has been a spleen volume reduction, SVR, 35% or more. That's by palpation, the physician or provider by touching the spleen, or it correlates with 50% reduction by an imaging. And then the TSS's total symptom score, that's the Rubin Mesa score that we now use worldwide, and that score has been invaluable. It's something that's phenomenal. We check it at 24 weeks, and in the ruxolitinib trials that Rubin helped to run, 46% of patients in the Rux versus only 5% had a 50% reduction in their symptoms. This scoring system has been so successful that Rubin and his team have translated it in over 50 languages, and it's used all over the world, not only now in clinical trials, but I think very nicely, Rubin, it's been incorporated into our own EMRs and used in the clinical practice day-to-day patients. How dramatic were these spleen responses? We've almost never seen anything like it. We had patients with such large spleens that they couldn't get out of bed that shrunk within days and weeks. This is called a waterfall plot. You may see it when you look up things. It tries to aim, it's actually kind of beautiful. What it's showing you is each individual patient is one of these bars. So you can kind of get a quick visual glimpse in 1 second of how did everyone on the trial do. So even if you didn't meet this cutoff of this 35% or whatever I showed you, you can see almost everybody with the ruxolitinib had a spleen improvement, which is pretty phenomenal. And this is the second study, which was Claire's study, which compared against best available therapy. So in this one, people received something different than placebo. Again, the drug got approved, platelets above 50. It can cause or worsen anemia and thrombocytopenia. And there are 3 long-term side effects you have to watch out for: weight gain, non-melanoma skin cancer, so basal cell squamous, and infections, opportunistic infections such as herpes zoster or shingles. So what about overall survival? There's some debate and controversy in our field, so if you look at our literature or come to the meetings, there are some who doubt that these drugs can actually help the overall survival, but actually in ad hoc or post-analysis after these trials were done, we and others have done pooled analysis, and actually there does appear to be an overall survival of benefit with these JAK inhibitors, particularly Rux. You have to be alive and well enough to be on them for a long time. You have to have gotten them at a good point. But if you get them at an optimal dose and your spleen shrinks, that appears to correlate with overall survival. Our group at the MD Anderson did a nice study looking at kind of improved survival, or how is survival in all myelofibrosis patients treated at our center over the last 10 years. So this is all comers, not just folks on a clinical trial. And to our surprise, we are seeing patients improve dramatically over time. Now, obviously, that includes a lot of variables. Patients have to be able to come to an academic center. Let's put that out there. There's a lot of other developments that have improved, right? Dr. Nangalia showed us, so better prognostication, gene, more motivated people, more information, more supportive care, more antibiotics. But you get the point that our patients are living longer and better because of JAK inhibitors. So that's the ruxolitinib. I think many of you know about it. But these other 3 JAK inhibitors are very important. The second one is fedratinib, as I mentioned, approved in 2019. This second-in-class JAK inhibitor had a couple of big studies that were run as well. That we call them the Jakarta studies. So again, it's an oral pill, JAK inhibitor. They all hit some other pathways besides JAK. But you can see here in this large study, patients with either post-PV or post-ET MF, intermediate to high risk as well. Platelets had to be 50 or more. You had to have some spleen. And you had to be a performance status of 0 to 2. You either got the fedratinib at 400 a day versus 500 a day versus placebo. This trial was also done actually a decade ago, a long time ago. And again, the primary endpoint and secondary, what I told you, the spleen and symptoms. So how did people do on the second fedratinib? It was either given as a primary treatment or in the other trial after ruxolitinib. And either situation it was given, it did show a decrease in the spleen, improvement in the symptoms, and it really represented the first time ever that we treated people with sequential JAK inhibitor. You had Rux and then you had the new one. Again, this drug got approved for intermediate to high risk, platelets 50 and more. There was one important side effect from this one, which was, and it does carry what's called an FDA black box warning. This one kind of unexpectedly had a signal in patients of what we call encephalopathy. So there is a GI signal, nausea, vomiting, diarrhea. You can have some problems with the neurological thinking function in some of the patients. And you can also have kind of a GI cachectic syndrome in some of the patients as well. When it was looked at, it looked like it was correlating with either fitness or thiamine levels. So we do check your thiamine level, vitamin B1, and then replace it. Ruben and colleagues and Claire did an analysis where they went back and looked. It was 800 patients treated. It wasn't exactly this unique syndrome of Wernicke's encephalopathy, which requires quite a bit of diagnosis by a neurologist, but more encephalopathy, really paying attention to the GI side effects. So it's one of these drugs where if I prescribe it to you, I'm probably giving you 2 or 3 other medicines along with it, thiamine, Imodium, nausea medicine, and then you have to talk about it together and know about this side effect. So each new drug with its promise will also have new toxicities. That's okay. We need to own that and know what those are. The third JAK inhibitor is that of pacritinib. This was led by our colleague John Mascarenhas, who's here. This is a very ingenious design which really looked at the toughest of the toughest group, those of you with very low platelets, which means inherently you have a higher risk of bleeding and other complications. The PERSIST-1 trial was the first one, as I show you here in the frontline therapy. Again, you can see the theme. Most of these are randomized studies, large numbers of patients, 327 here. The new drug, pacritinib, 400 a day, versus best available therapy, which at that time did not include the ruxolitinib. Same primary and secondary endpoints. The PERSIST-2 really focusing on the thrombocytopenia, the low platelets, including both frontline and second-line treated patients. A 3-way randomization, again, 300 more patients. Pacritinib at 400, pacritinib 200 twice a day, so split dose, and then best available therapy. I think what's amazing about this drug is, again, it's the second time where you see a JAK inhibitor given after Rux, so a particularly higher risk group of patients, a tougher expectation, if you will, but also given up front too. Here again, you see a little bit of a signal for GI side effects. Particularly, you should know there could be some diarrhea in the first few weeks and months. And there was some concern earlier in the development of this, could it be increasing the bleeding or cardiac signals? Actually, John and I and others look back, it doesn't appear that that was the case, but there was some concern for that. Ultimately, the drug gets accelerated approval for intermediate to high risk MF, specifically with platelets less than 50, but I'd like to emphasize that I and others routinely prescribe it above 50, particularly in the second line and beyond, and that's in the NCCN guidelines as well. Now, the question about pacritinib, there was some start and stop in the drug development, is we asked the question, can it actually improve the overall survival, as I showed you with the ruxolitinib? In fact, it does appear to, and just like the prior JAK inhibitor, probably this overall survival benefit depends on dose optimization, spleen size reduction, and you need to be on it long enough to be able to be assessed. So these first couple of JAK inhibitors, some of them were able to be followed for OS, some not, but we can go back retrospectively and see that people are benefiting by and large from these. This is one of the analyses I mentioned to you that we did to just look back at the pacritinib, which again is very safe and effective in the clinic. Really, in my own analysis that we led, we didn't see a major signal for these bleeding and cardiac risks. So in the real world, yes, because they're already low platelets, watch out if you're on blood thinners, watch out at the time of surgery, watch out if you have cardiac disease. But this did not appear to be a major limitation, and it remains not one in the clinic. The fourth JAK inhibitor team is that of momelotinib, and this was a couple of studies, Simplify 1 and 2, and then the Momentum study is shown here. I really want to show you this study because, again, each one of these studies improves the field, gives another new area for drug development and new ideas. Take a look at this trial. So this one was previously treated patients. You had a JAK inhibitor, you had to have symptoms, you had to have anemia, and patients about 200 in a 2-to-1 randomization. You had to be off your JAK inhibitor for 3 weeks or more, went on the new drug, momelotinib, 200 daily plus placebo, versus the control arm, which in this case was danazol, an older drug that we've all given and used and studied that can help anemia in patients, plus placebo. So double placebo blinded study, and then everyone can cross over to momelotinib if they didn't have it before, after the 24-week time period. But what's really cool about this study, the primary endpoint for the first time is not the spleen and symptoms. It's actually the symptoms alone. And then in the secondary endpoints, because there's an anemia signal, transfusion independence, and the spleen. In this study, in addition to showing benefit in the spleen and symptoms, there was a very nice signal for anemia improvement, which we saw in the earlier trials. Transfusion independence shown here at week 24, so improvements in the hemoglobin, and if you needed transfusions, improvements in those in many of the patients. Ruben had a nice analysis where he showed that many of those patients then can correlate with overall survival if you reach transfusion independence. The reason why these 4 JAK inhibitors are so important is that many patients, even if they can get them, you can have side effects, intolerance, complications. And so the problem is, after you come off the JAK inhibitors, we do not have any approved targeted therapies yet. We're working on them, as you're hearing. This is a sobering chart to show from our group that if you really come off the ruxolitinib because of either platelets are too low, you have too many new mutations or clones, you take a chronic disease, MF, and now it becomes an acute, life-threatening one, and sometimes the overall survival can be less than 2 years. Our colleague, Dr. Palandri in Italy, showed that in a group of 218 patients exactly like this, outcomes are not so good. Even though these therapies have revolutionized care for many of you, most of you are off these drugs by 3, 4, and 5 years. In their study, almost half the patients, 41%, were off the Rux at only 3 years, and many of them were for bad reasons, not tolerating the drug, some kind of side effect, infection, something else is happening. Only a few people coming off for a good reason, say allogeneic transplant. And so what it tells you is, yes, we have revolutionized the field together, but we are not curing the disease largely with these pills. So we must keep working with you and for you. Immunotherapies, as you heard from Dr. Nangalia, CALR, mutant-specific with JAK2 and others, novel agents going beyond the JAK-STAT pathway, and then optimizing allotransplant for those of you who can go for it. We put together a paper that we really wanted to put these thoughts down on with Penn, and I think what I'm thinking, and this is something that I would posit to you, we owe this to you. Beyond the JAK inhibitors, can we do 3 things? 1, can we treat your disease earlier? You heard the talks from ET and PV. Can we treat it more aggressively? Combination therapy up front, novel therapies, but with that comes extra financial toxicity, patient toxicity. We have to show and prove that in trials that that's okay. Then can we optimize immunotherapy, stem cell transplant therapy? I think the host of novel therapies is increasing weekly. That's something good. So we thought this was going to be this comprehensive chart we put together. My goodness, this is already outdated, but in a good way. So check out clinicaltrials.gov. Clinicaltrials.gov, it's a free website. You can check it. It's updated regularly. That'll tell you all the trials in the country going on for the MPNs. But remember, we're trying to work outside the cell, immunotherapy. Inside the cell, outside the nucleus, targeting pathways, and then at the level of the nucleus. We've borrowed from every field you can think of. Ruben has some great stories, so if you find him in the break, GI, parasite biology, cardiology, you name it. And so now instead of borrowing from all these MDS AML, we have our own companies, our own drug development, our own collaborations, as you're seeing here. And so what I would conclude with to say is that JAK inhibitors, the 4 that I showed you, are the backbone of our MF therapy. They remain the standard of care. Remember that allogeneic stem cell transplant, if you're able to go, there's many variables that prevent. Let's go for that if you're intermediate to high risk. Let's go for one of these combination clinical trials if you benefit. And then for the transplant, we're getting to the point where we can transplant folks who are older. Different donors are now available than when I first started 25 years ago. So not just from a sibling or a stranger, but maybe even a mismatched donor, or what we call a half-match donor, haplo from a son or daughter. So that didn't exist, 15 years ago. And so I would leave you with thinking about myelofibrosis as a disease of many faces, one that can either be chronic and measured as a low risk in decades, or one that can either change on a dime or present as an acute life-threatening pre-leukemic condition with an overall survival of less than 2 years, we now have the tools, ladies and gentlemen, to be able to diagnose your myelofibrosis, prognosticate it with you in the clinic, so that's the cytogenetics molecular, standard of care therapies, as you heard, and then investigational therapies that either combine or go beyond, and then the stem cell transplant for those who qualify. With that, I'd like to thank all of you, our patient community, and in particular, some of my key mentors, Alison Malterno from Johns Hopkins, Ruben Mesa, and Marina Konopleva, who's now in New York. And thank you all for your time and attention.